All to that. Welcome you all to this Ampok case presentation. So as you all people are aware that Ampok is organizing this monthly academic meeting for targeting the postgraduates. And I feel like it's not only the postgraduates, but even the consultants are actually benefiting from the quality of discussions which we are having at this forum. So I request Dr. Munir to take over the proceedings. Over to you, Dr. Munir.
Thank you, Bobin sir. So this is our 33rd Ampok ISMPO IMO PG case presentation. Today we have as a presenter Dr. Sarah Wilson. She is a second year DRNB postgraduate from Astra MIMS Calicut. And we have two eminent examiners today. One is Dr. Arun Varya. Sir is the senior consultant at Astra Medicity Kochi. And Dr. Rahul Ravind, sir is from Rene Medicity, Kochi. Over to examiners for the proceedings. Rahul sir and Arun sir, please take over.
Yeah. Good evening and good to be here, and thanks for this opportunity. So I think we will, Dr. Rahul, I think we can proceed with the case presentation.
Yes, sir. Yes, sir.
Yeah, we'll start. Yeah, please. Doctor, you can start with the case.
Yes, sir. Yes, sir. Good evening, everyone. So today I'll be presenting a case. So we'll start.
Can you
with
switch
the
on the video? The video you can switch on.
Yeah.
So that.
1 second. So video showing, sir.
No.
I switched it on from here, sir. It's not. Yes.
Yeah, please. Yeah, let's proceed. Yeah.
Presenting the case of Mrs. J, a 40-year-old lady with no known comorbidities, a homemaker by profession. She presented with chief complaints of left lower abdominal pain for 3 weeks, constipation for 2 weeks, and fatigue for 2 weeks. She was apparently well till 3 weeks back when she noticed left lower abdominal pain. The pain was noticed initially as intermittent and dull aching in the left lower abdomen, which would resolve by itself initially without painkillers. Over the next few weeks, it increased in duration and in intensity. There was no radiation of pain elsewhere, no aggravating or relieving factors. This was also associated with constipation, but there was no alternating loose stools with constipation, no blood in stools, no abdominal distension or vomiting. There was also a history of fatigue for the past 2 weeks associated with appetite loss. There's no history of obvious weight loss. There's no history of fever, no history of cough, breathing difficulty, breathlessness on exertion, no history of difficulty in swallowing food, vomiting, or blood in vomitus, no history of increased frequency, urgency, or hematuria, no history of vaginal discharge or bleeding, no history of low back pain or bone pains, no history of headache, vomiting, or seizures. In the previous treatment history, she presented initially 4 years ago to another healthcare facility with complaints of abdominal tightness and distension. She was evaluated from there and imaging and blood tests were done. She was found to have a malignant left lower abdominal mass for which she underwent surgery followed by chemotherapy for 6 cycles. She was kept on regular follow-up and was asymptomatic till date. Going to the past history, there is no history of any comorbidities in the form of diabetes, hypertension, cardiovascular disease, asthma, or TB. In the menstrual history, she attained menarche at the age of 13. She was married at the age of 22. She had regular menstrual cycles. She's P2L2. First childbirth occurred at the age of 25. She breastfed each child for more than a year. There's no history of OCP use. Personal history, no history of any addictions. Family history, there's a history of ovarian cancer in the mother, diagnosed at the age of 45. The mother died 4 years after starting treatment. She underwent surgery and chemotherapy, but the actual details are not known. There's also a history of breast cancer in the mother's sister, diagnosed at 50 years of age. She is still alive. She also underwent surgery and chemotherapy, but the treatment details are not available. So, summing up, this is a 40-year-old lady with no significant comorbidities, with a significant family history of malignancy in the form of ovarian cancer in her mother at a young age, 45 years, breast cancer in her maternal aunt at the age of 50 years, and she had been diagnosed herself with an abdominal mass 4 years back. She was treated for the same, and she had been asymptomatic for the past 4 years. This time she presented with left lower abdominal pain for 3 weeks, constipation for 2 weeks, and fatigue for 2 weeks. Shall I go ahead with the...
So we'll just wait here. We'll just wait here. So Dr.
Yes, sir.
Rahul, you would like to start, please? No problem.
Yeah. So at this point of time, Doctor, can you tell me what could you come up with some differential diagnosis, or what are you thinking? What lines are you planning to proceed?
So she's a young lady. She already has a history of a malignancy 4 years back for which she was treated. It was a lower abdominal mass, and she's been asymptomatic for the past 4 years. This time she came with complaints of an abdominal pain and constipation. So I would like to proceed first. When she came to us, she had already done an imaging from outside. But for this patient, we would like to first proceed with complete history and physical examination, sir.
What are the differentials? What are the
DDs?
Differentials are keeping the possibility of maybe a gynecological malignancy like a ovarian malignancy. That's the first differential. Relapsed ovarian malignancy. Secondly, we have to keep a possibility of a possible colonic primary.
Okay.
Anything apart from malignancy that you can think of?
Apart from malignancy, sir,
But in the background of malignancy, you are more towards malignancy. I think that's the reason.
yes, yes.
Always, the common will is tuberculosis. No, tuberculosis can come anywhere.
Okay.
Right. So I think you can tell what treatment means. That's fine. It's a medical oncology super specialty. So you can the history. You can tell what the diagnosis was there previously. That is fine. What was the previous diagnosis? It was CA ovary.
CA ovary.
CA ovary. So at that time,
Yes,
surgery, everything was done. No? It was completely
surgery was
treated.
done. Yes, sir. She underwent upfront surgery.
Surgery, chemo, everything
Yes,
was done.
and then followed with adjuvant chemotherapy. Yes, sir.
Everything was done, right. So somebody with a strong family history also is there from your history. So what
Yes,
are the any other than ovary and colon? Any other possibilities are there? They are received some chemo also before. So,
sir, the family history wise, if there's a history of ovary and breast, we are keeping a possibility of HPOC, BRCA-related syndromes.
okay.
So,
that what are the other tumors which can come up?
So BRCA associated can be breast cancer.
For completing a differentials, yeah.
For differentials are
the secondaries will be very difficult, very unusual. Yeah, okay.
Then so pancreatic.
What are the other BRCA-related cancers which can? Yeah.
Pancreatic cancer.
Can present like this? Pancreatic cancers.
Pancreatic cancer usually will present with an upper abdominal pain, satiety, early satiety, weight loss.
I think for completing the differentials, that can also be there. No? Peritoneal disease and pancreatic cancer.
Yes, yes.
Or any other cancer.
Then gastric malignancy can be there. It is with BRCA. There is some association of gastric cancer.
Fine. Sarcomas. Any?
Sarcomas, breast. I'm not sure. Sir.
No, not breast. Abdominal sarcomas. Retroperitoneal sarcomas. or can be there. They are more predisposed to all these malignancies anyway. Yeah.
And primary peritoneal
Same.
carcinoma also something you can say. PPC is also something you can.
Fine. I think we will go ahead with
You
the
can
investigation.
proceed.
Yeah.
So on general physics physical examination, she was a moderately built and nourished lady. ECOG PS of 1. Height was 164, weight of 65, BMI was 1.7, pulse was 90, regular volume and regular rhythm, normal volume, regular rhythm, respiratory rate of 18. She was afebrile, BP was 20/60 in the right arm supine position. There was no pallor, icterus, edema, no significant palpable lymphadenopathy. Her thyroid and breast examination were normal. On per abdomen examination, she was inspected first in the supine position. The abdomen showed a healed vertical laparotomy surgical scar. There was no obvious visible swelling or distension, no dilated vein, sinus, or fistulae. All quadrants were moving equally with respiration. There was no visible peristalsis. On palpation, on superficial palpation, there was no tenderness, no obvious masses palpated. However, on deep palpation, there was a firm, ill-defined mass palpable in the left lower abdomen, approximately 5 into 5 centimeter, with mild tenderness on palpation. There was no shifting dullness or fluid thrill, and bowel sounds were heard normally. In the chest, there was no visible scars or dilated veins, bilateral equal movement with respiration, trachea was central, with normal breath sounds heard bilaterally.
Did you do this thing, rectal supervising examination?
For rectal and PV, I didn't do so on this patient. Mr.
Sam, setting you're supposed to do that, no? Anyway.
Yes, sir. Yes, sir.
Fine, okay. Right? Carry.
You cannot miss a PVPR investigation in this case, especially
Yes,
when
sir,
this
yes.
patient is having a history of constipation.
Yes,
So
sir.
it has to be done. Please don't miss it for your final examination.
Yes, sir. Yes.
And could you please tell me where is this exact location as per the quadrant? So it's written left lower abdomen. So better you should say
But
at what quadrant the mass that you could feel.
It was not exactly in the iliac fossa, between the left lumbar and iliac fossa, sir. That area.
So suppose you were given the chance to do a PVPR. What are things you will look into in this case?
So PV, sir, we have to look for. We can do a bimanual palpation. It helps us to first of all, if we do it upfront, it helps us to. If we do it upfront, then it helps to. It will help tell us about the ovarian. If it's an ovarian mass or a uterine mass, we can make out. Secondly, if the mass is palpable, then we can make out the character of the mass, the size of the mass, and the consistency.
Yeah, fine. So a lot of information would have come. Anyway, right? Proceed. Yeah.
Fixity and.
Yeah.
So doctor, can you tell me what was the surgery that was done in the past?
So she underwent a staging laparotomy, sir. Cytoreduction was done.
Okay. And what do you expect to see in this patient? I mean, who is underwent surgery? What are you going to see in a PV and a PR examination?
On the PV examination, the vaginal vault will be palpable, sir.
Okay. And anything on the speculum that you can see, or that you would think that there will be something suspicious?
No, not POD nodules, sir. Not sure.
Yeah.
I'm not sure. Okay. And sometimes you can have wall deposits also. And the rectal, what are you expecting? Because the patient is having constipation, so do you think that you're going to feel something? Yeah.
No, so whether there's any intraluminal or any means any colonic lower rectal deposits, or infiltration or any primary rectal mass.
Okay. Yeah, you can continue. Yeah.
Yes, sir. Chest examination was normal. There were
Yeah,
no
otherwise everything was normal. No? Otherwise everything
Yes,
was
sir,
normal.
yes.
Systems
Yes,
were normal.
yes.
Fine, that's okay.
Yes,
Yeah.
sir.
So only thing you got was you want to sum. Okay.
Summing up, we have a history with.
I think there is nothing much here, so we have we won't waste time. So only one thing you added is the left lower abdominal mass. That's all. That is there in the examination. So anything else? Any other information you got from your examination, or any other differentials you'd like to add or reduce?
So I would still like to keep a possibility of an ovarian relapse versus a colonic malignancy.
No, but you are feeling this mass now. So what is this mass?
Mass is, sir, it may either be a serosal or a peritoneal deposit versus a maybe a colonic mass that is infiltrated the serosa and the peritoneum.
colonic mass. It's very unusual, no? To feel a colonic mass, 5 into 5 centimeter colon mass. How is it usually colonic mass? Have you felt colon mass like that?
No, usually,
By
no, sir.
examination? It's not
No, sir.
possible.
No, sir.
Yeah.
Hmm.
Colon need not bring in colon. It's Dr. Rahul. I think we need not bring in colon. We can just say peritoneal deposit and yeah.
Yeah, you could say it's a lower pelvic mass. Probably it could be a peritoneal deposit. That would be the safest way to go.
Safest. Colon will always land you in again trouble. Yeah.
Okay.
That is safest thing. Yeah. So you're feeling a peritoneal. Somebody was undergoing upfront cytoreduction. Yeah. But
Yes.
then whether it will be so well palpable, I don't know, because we are not examining the patient. So that is a tough thing to do. Anyway, so we'll go by your findings. Fine. Yeah. Fine. Okay. So that's also, we are not anyway wiser even after examination. So now we have to ask for the investigation. Okay, proceed.
So, the previous
Yeah,
history,
previous,
sir. Previous history initially in 2019 when she was diagnosed, an MRI was done which showed a left adnexal mass and a left external iliac node. CA-185 at that time was 600. She underwent an surgical staging, brought me, and the HPR was a high-grade serous carcinoma involving bilateral ovaries 1C2. Lymph nodal examination is negative, sir. Lymph node negative.
So we'll just hold you there. So I think we will start from here. So there was a left adnexal mass and a left external iliac node upfront. So is it a case where you can do upfront surgery or anything? What are the scenarios where you won't do any upfront surgery?
So upfront surgery will be, we'll keep it at the discretion of the surgical oncologist. If they feel that the malignancy can be resected upfront and they can get an optimal cytoreduction or a complete cytoreduction, then we'll proceed first with surgery and then go on with adjuvant chemotherapy according to the histopath.
No, from your side, how do you decide? Other than, yeah, what are your radiological findings of unresectable?
Unresectability, sir, if there's extensive peritoneal deposits, especially involving the small bowel, then diaphragmatic peritoneal, extensive peritoneal deposits, then stomach infiltration, extensive liver infiltration, splenic infiltration, then rotomesentery, bulky rotomesentery.
That's
Then,
okay, right. Yeah. Dr. Rahul, this, yeah, that's okay, fine. That's, I think, So left external iliac node. Dr. Rahul, you have any comments on that? External iliac.
No, so the node was being on the MRI, right?
Yeah.
Yes, sir.
And at that time, this was basically it has been surgically staged as 1C2.
Yes, sir.
And the left iliac nodes were negative, right?
Yes, sir.
So iliac node was negative. Okay, then that's fine.
Yeah.
Okay.
Okay.
So if the node was positive, then what would be the stage?
If the node was positive, it would have been stage 3A, sir.
Fine.
Yeah, okay.
1C2. Fine. Okay. So with such a family history, did they do any BRCA at that point? With
So at that time,
2019?
it was not tested, sir.
Not tested. Okay, fine. We'll go later. Fine. Okay, now after this, adjuvant was given. Stage 1C2.
Adjuvant was given, sir. She received 6 cycles of carboplatin and paclitaxel, sir.
Okay.
And after that, she was put on follow-up. So she was following up with that healthcare facility for the past 4 years. So she came to us when she had these symptoms.
Okay, yeah, proceed.
So this was her CA-185. It was done from outside. It was 1,244. CA was 6. This was a CT scan that was done from outside. It was showing a well-enhanced soft tissue density lesion in the muscular layer of the descending colon, anteriorly with subserosal extension and surrounding maintained fat plane. It was causing luminal narrowing and extending into the paracolic gutter. Luminal narrowing with enhancing wall thickening was also seen in the rectum, making an ill-defined fat plane with the base of the bladder and part of the cervix. And there were multiple nodes seen in the form of para-aortic, gastrohepatic, portal, mesenteric, and pelvic nodes.
So this is a very intriguing CT scan report. So,
Mm.
so based on the CT scan, what do you feel it is?
Based on the CT scan, sir, it can either be a ovary with extension, means relapsed ovary with extension to the colon, or we have to keep a possibility of the primary colon also. Sir.
CT scan, whether we will be able to tell from the muscular layer of descending colon. I'm not sure. Isn't it? It's like a pathology report. Anyway, a very good radiology. Any comments, Dr. Rahul, on this? I don't know. It's very unusual.
Exactly, sir. It's very difficult to say.
Yeah, that's
And,
fine. Okay. So what's the next step?
Yeah, it's very difficult to say.
Yeah.
So if you're telling
proceed.
more from the or if you're telling more about the muscular layer, then you should think about some other DDs. I mean, some colonic tumors that's arising from the muscle layer. Then that will also come in your DD. Anything that you can think of?
Just, sir.
Arising from the muscle layer of the colon or rectum.
So just.
Yeah. Yes. Yes. Or is it only the CT?
CT, sir, when we went into the colonoscopy, sir.
Yeah.
So the colonoscopy showed an ulcerative growth. It was 3 to 3 centimeter in size with luminal narrowing at the descending colon. So we took a biopsy. It showed moderately differentiated adenocarcinoma. The HPR was suggestive of ovarian primary. PAX8 was positive, WT1 was positive, P53 also was positive, and SAT-B2 was negative, sir.
So what are the basic markers you do? These are little second-level markers. What are the first-level markers to differentiate between colon and ovary?
Sir, CK7 and CK20, sir.
So how will it be in ovary?
CK7 will be positive in ovary, sir. CK20 will be positive in colon, sir.
Plus minus and minus plus. Fine. Okay. So that we don't have the report. I think directly they're going for the next level. Okay.
Yes, sir.
So now it is a high-grade serous carcinoma or vaginal. So what will be the stage at this point now?
Stage, sir, it will be stage 4. Because of
it's a soft tissue nodule. It's a peritoneal nodule infiltrating colon, isn't it?
Yes, sir. But it's infiltrating the substance of the colon. So I thought.
Okay.
Have you done any other staging investigations apart from a CT abdomen and colon? Is there anything else that you look?
Sorry, sir.
Have you done any other staging investigations?
No, sir.
So it's just the CT abdomen and colon. So do you think that you have to do any other site staging?
So chest was done actually. Sorry, chest CT chest I have not put in the CT chest was done from outside. That was normal, sir.
So you're putting like a stage 4 ovarian cancer at this point. Yeah. After 4 years. No, relapses after 4 years.
After 4 years, yes, sir.
Right. Patient is 64 years, otherwise well preserved, isn't it?
No, sir, she's 40 years, sir.
40 years.
44 now.
44.
not 64, 44. 44 relapsing after 4 years. So what are the thoughts that come to your mind now? What are you going to tell them? They're asking you what is the treatment here?
Treatment is, we're thinking of a platinum-sensitive relapsed ovarian carcinoma, sir.
Right. Fine. So what will you offer next step?
Next step is, sir, when there's a platinum-sensitive relapse, we again have to get an opinion from the surgical oncologist if they feel that a secondary cytoreduction is possible. If it is not possible, then we go ahead with chemotherapy. Because it is platinum-sensitive, we can re-challenge her with platinum.
What do you feel in this case? Is a cytoreduction possible or not? What is your opinion?
No, sir, because there's
because there is
There's extensive nodal involvement and there's invading into the rectum, the bladder, and the colon.
Okay. So definitely it's not a case for upfront surgery anymore. Yeah.
Yes. So then we'll proceed with the platinum doublet, sir, chemotherapy.
What is your preferred agents of choice in this case?
So we can give her, we can again give her carboplatin and paclitaxel if she is not having any previous side effects of the previous chemotherapy, or other options are carboplatin lipodox, liposomal doxorubicin, or carboplatin gemcitabine.
What is the commonly, what is your
What
practice?
is your preference?
Yeah, what is your preference here?
We here we usually give carboplatin gemcitabine, sir.
Yeah. But then she is 44 years only, no? She is not having
She's 44.
neuropathy. And, yeah.
So she the initial chemotherapy that she was given from outside, she did not tolerate it very well actually. So after that, she had neuropathy for around 2 years.
Now it
After
is restored.
paclitaxel. Now it's results, yes, sir.
So which one do you feel is a better, which one will give the better action? Means at least response-wise, which one will be the best among all these options?
Response rates
I know
are
there are no
carboplatin.
head-to-head comparison like that. Yeah, but still,
Mm.
here clinically, which one do you feel will give us the best response?
So carboplatin, lipodox,
Liposomal
liposomal.
doxorubicin. Yeah, what is the dose you give? This liposomal doxorubicin carbo combination.
Carboplatin dose will be say AUC 5,
Mhm.
and liposomal doxorubicin it is 40 to 50 milligram per meter square, sir.
No. It's
So
actually
don't give
when you're
ranges in examination, please. You should tell us specific dose.
40 milligram per meter.
So in combination, even 30 is okay, but then up to 32, yeah, that is fine for combination. But then it is given once in every 28 days. So definitely the drug intensity is going to be less, isn't it? Carboplatin ideally AC5 we have to give 3 weekly. So what most of us feel is that it may not, for a patient not fit, fine, but then here you are a young patient whom you want the best response. So maybe cyclic carbo is what most of us may resort to. The neuropathy is discipline.
Yes. Yes. So what dose of paclitaxel would you give for this patient?
Paclitaxel, sir, ideally it should be, we can again rechallenge it 175 milligram per meter square. In frail patients, they have at least 135 milligram per meter square, or we can give a weekly dose also, sir.
Okay. So what do you think is the problem with the weekly dosing versus the 3 weekly dosing? Which is better? Better tolerated? What's the toxicity profile for this thing? And what do you think is about the outcome regarding a weekly versus a 3 weekly regimen?
The outcome, so there was a Japanese trial, I think, sir, about weekly paclitaxel. In that, it was when they reduced the dose down to 60 milligram per meter square, it was tolerated better in the elderly population. Otherwise, the incidence of neuropathy was
but what was the
weekly. The actual dose was 80 milligram per meter square. That caused that had more incidence of neuropathy, sir, and cytopenia.
And some studies of pulmonary toxicity also.
Yes.
So can you quickly tell me how do you write a chemo chart for a paclitaxel plus carboplatin? What would be pre-medication, drug with infusion rates, and your post-chemo medications?
So pre-medications are usually we start one day before. We pre-medicate with dexamethasone 8 mg twice daily on day 1, the one day before the chemotherapy, the day of chemotherapy, and we continue one day after. Then we give on the day of the chemotherapy, along with the steroid, we also give Rantidin 50 mg, Avil 1 ampule of Avil, and for because of carboplatin, we'll also give aprepitant or fosaprepitant. Apricap dose 125 milligrams.
Okay.
Then we will. Then we will give paclitaxel. The dose is 175 milligram per meter square, sir, given over 3 hours, followed by carboplatin AUC 5 to 6. That is given in a 5% dextrose bottle, 500 ml, 5% dextrose over 1 hour.
Okay, so can you just tell your pre-medication one more time? What all do you give in your pre-medications?
Pre-medications are steroids.
Okay.
I think they are giving steroids for 3 days, no? The Dexa day 0, 1, and 2. That's what I understand.
Sorry, I
3
got
days.
confused with docetax. I got confused with docetax,
Yeah.
sir. We give on the day before and the day of, sir. Yes, sir.
Yeah, that's fine. Yeah. So can you give docetaxel in this case? If there is significant neuropathy, can you substitute with docetaxel?
We can substitute.
Possible.
No, sir.
NCCN gives you the option. No, NCCN
No.
gives you the option. You can give that. There's nothing preventing you from that. Because if you really want to give taxanes, you can do that. Yeah.
Okay.
If the neuropathy is a problem. It's not commonly done, but NCCN does agree for that. Yeah. Fine. So now we are going to start with chemo. Right.
Yes.
That's what I understand. Any other tests you want to show? So this is all. You're now going to treatment. What's it?
We did a BRCA testing on her, sir. Germline BRCA tested was pathogenic. Yes, sir.
Okay, fine.
And apart from that, we have to do the routine testing also, sir. Complete blood count, renal function, liver function, vital markers.
So this is the last slide. Slides are over. Or any more slides are there?
As a treatment, what we gave us.
So this is what you give. Okay.
Yes, sir.
Okay.
So we are given a
we can
count.
proceed now, Dr. Rahul. Rahul, you can.
Yeah, yes, sir.
Poor tolerance to chemo. That's very unusual. What you this case you have seen?
Yes, sir. Yes, sir.
What happened?
She was having recurrent admissions with cytopenia, sir. Then severe nausea, vomiting, and cytopenia. That was the main thing, sir.
So how did you manage nausea vomiting? You were giving aprepitant before, no? So what else did you do for that nausea and vomiting?
So we had changed it to she got aprepitant, then we had made it fosaprepitant. Then we after that we gave an we changed to necubitant and palosetron combination also we had given. So.
Okay. It is very uncommon for
Doctor, can you tell me what?
Please.
Yeah. So what is the emetogenic potential of this regimen that you have told? Gemcitabine plus carboplatin EC5.
So high emetogenic potential, sir.
Okay. So for a high emetogenic potential, usually what is your drug of choice for these patients? Or what do you practice in the institution? That's what
to give 4 drug combinations, sir. For that we give steroids, then we give olanzapine, sir, 5 to 10 mg on the day off and 3 days following the chemotherapy. Then we give apricap, and we give this MSET, sir.
Okay, MSET. Okay. So between MSET, granisetron, palosetron, which is your preference?
We
and
use
why?
MSET.
Okay.
We commonly use MSET here.
So
MSET
if you're using palosetron, the patient has a longer, palosetron has a longer duration of action.
Yes.
So
Yes,
it actually takes care of the delayed CMV also to a certain extent. So if the patient is not already because vomiting, it's better to give a palosetron which is long acting.
Okay.
Cytopenias in the form of what? What was the main issue? Cytopenias?
Thrombocytopenia and neutropenia also.
Okay, neutropenia is eminently manageable with colon-stimulating factors. And what is your comment on using this newer L-thrombopag in chemotherapy-induced thrombocytopenia? Is there any data? Are you doing? You're not doing it.
We're not using it routine. I'm not sure, sir.
Not using routine. Okay, but you have heard about that?
Yes, sir.
Thrombopag and
yes,
all?
sir. Yes, sir.
Okay. Right. Okay. So what happened means after that, a good response was there on imaging. C1 dropped to 5 from 1,200.
Yes, sir.
Okay. Have you heard of something called a scaling? It may not be relevant here, but
yes, sir.
is there something called as, what is it?
Yes, sir. Kelm score is we see the kinetics of the CA125 after starting the patient on usually on neoadjuvant chemotherapy. So we have to do 3 scores. You usually see 3 scores. And if there is a constant drop, and if this Kelm score is more than 1, it points to chemosensitive.
So are you doing that? How do you do that?
Yes, sir. We're not doing it here.
Have you tried one patient? How to do that?
No.
Actually, it's an online tool. Online, you have to just key in the CA125 values and nice graph will come. So it is good to do that. So that that is only extra thing which from Madon's side you can do. Okay,
Okay, sir.
right. So anyway, imaging is fine. Okay. Cytoreduction was done.
Yes, sir. After 3 cycles, she underwent cytoreduction. Is the HPR report is this, sir. So there was that the subserosal deposit was there. All the other nodes were negative, sir.
Okay. So anything more you could have done other than just doing a cytoreduction?
Sir, there is an option of doing a HIPEC also, sir, in such patients.
So will you have offered it to her?
I think because she had had a stormy course in her chemotherapy, we didn't give her the option, sir. There is an option of doing HIPEC, sir.
Okay. So yeah, suppose in upfront case after neoadjuvant, is
Yes,
there a
sir.
role for doing HIPEC?
Yes, sir, there is a role of doing HIPEC, but it has to be discussed with the patient in detail. They have to
Yeah.
be in good, they have to have a good PS, good health, and they should have good renal function. And if they
Are you
are
doing it in a
motivated,
center? HIPEC you are doing?
we are doing HIPEC, sir.
So what is the drug you are using?
Cisplatin, sir.
Dose?
Dose 75 milligram per meter square, sir.
Yeah, 100 is the recommended, but I think most of
Yes.
the give 75 to 100.
And
And what is the height? Yeah. What is the temperature? Minimum.
Temperature is
that you have to
42 degrees Celsius, sir.
give? 40. So HIPEC you would have offered, but then yeah, Dr. Rahul, anything?
If it's for this patient upfront, would you choose HIPEC or would you choose bevacizumab bev-based regimen? So what would be your preference between the both? Considering the patient has a good PS and organ function. And let's not bring BRCA into the picture. Considering upfront at the age of 40, when the age of 36 when she presented. So what would be a choice?
Sir, if upfront, actually, she had a resectable disease.
Okay.
So
Suppose
bevacizumab is proposed for those who are either stage 3 or stage 4 incompletely resected, or those who have an pleural effusion ascites.
Okay. Suppose if this was a stage 3, then between the questions between HIPEC versus a bev-based regimen. So what would you prefer?
We can go ahead with bevacizumab, sir.
Any trials that you can think of which is superior or which is just showed some benefit, or which is where HIPEC doesn't show much of benefit?
HIPEC trial had shown benefits, sir. There was that OV HIPEC trial was there, sir. That had shown PFS and OS benefit, but the other trials following it had not shown OS benefit.
And when there are trials where they have tried bevacizumab also, where they didn't find much of benefit or added benefit when you're doing a HIPEC also. So it's a debatable area. So you can say what is done in your institution. That's a safe way to come out for these kind of questions.
Okay.
Yeah. Okay.
So I think one thing against HIPEC was she had extensive nodal involvement. So such an extensive, she had extensive nodal involvement to begin with. So maybe that is again. Right. So you want to start on olaparib main because she's BRCA positive.
Yes.
But then somebody with such a bad cytopenias to carbogem, what do you expect with olaparib?
Yes, olaparib is associated with anemia, thrombocytopenia, and neutropenias. But we started it around 1 month back, sir. On her first follow-up till now, she's okay.
Okay. Right.
What are the side effects of olaparib?
Olaparib can cause anemia, thrombocytopenias, neutropenia, gastritis, nausea, vomiting, liver dysfunction, sir, and fatigue.
Okay. What about the nausea vomiting for this patient? How does she tolerate olaparib?
Now she's not. We gave her PPI, sir. She's not having PPI. She's not having nausea vomiting, sir.
So if you look, certain trials have told that olaparib can actually turn out to be like a moderate to high emetogenic drug. So it's better that you give antiemetics of IHT3. And
Okay.
what are some of the late side effects that you can think of with this patient who is being exposed to olaparib?
So MDS.
Yeah, MDS AML. Yeah.
And what about the breast cancer? She's having BRCA positive. So how are you going to follow up for breast cancer in the?
So ideally, we had advised her for risk reduction surgery, sir. She was not willing.
Okay.
So she's been put on follow-up for that. So we should ideally do her age is 40. We should ideally be doing a 6-monthly mammography, annual mammography and annual MRI, spaced 6 months apart, sir. Then also advise her for clinical self-breast examination.
So what is your lifetime risk for developing a CA breast, BRCA positive?
Sir, in BRCA1, it is around 50 to 70%, sir.
So that's a very high risk. So already she has got a CA already. So
Yes.
now she had a poor. So you are not able to continue the chemo also, isn't it?
We could not give more than 3 cycles.
Okay. Right.
Probably the cytopenias could be explained because of a BRCA positive status. And sometimes BRCA patients, when you expose them to chemotherapy,
but then this
even
4 years break pass, that is still unusual, isn't it? 4 years break is
that
unusual.
is unusual. Yeah. So how do you do a genetic counseling for this patient who's BRCA positive? She's P2,
Yes.
L2, strong
Yes.
family history.
Yes.
How do you do a pre-test counseling, doing the test and post-test counseling in brief? You can tell.
The pre-test counseling is, so this is for a upfront patient who doesn't know BRCA status or known BRCA status?
Yeah, doesn't know BRCA status. Okay. Or
So,
before you do a
pre-test
BRCA testing for this patient, how do you counsel?
Pre-test counseling is, sir, for those patients who have a family history of either ovarian cancer or males with breast cancer, any history of pancreatic cancer in the family, or history of breast cancer, especially triple negative breast cancer, bilateral breast cancers. Those patients we advise for BRCA testing. Before we undergo the testing, they have to be counseled about the possible results of the test and what if a test turns positive, what it would entail, regular follow-up screening and risk reduction surgeries.
Yes.
And she requires psychological
Yes.
counseling also.
Right? Yes. And anything for the family members, for the siblings, for the daughter,
Family members, sir?
for the family?
Yes, sir. Yes, sir. For the children, for daughters at the age of, they should start screening at the age of 25 for breast cancer. At the age of 18 onwards, they can be advised to start self-breast examination. From 25 onwards, we have to start screening with MRI, sir. MRI mammography. And 25 to 30 onwards, we have to add mammography plus MRI, both together, sir.
Suppose, sir, the BRCA was negative. So this HRD is a big thing nowadays. No? So we do have advised
Yes,
HRD, or whom do you advise HRD testing? Whom will you advise
HRD
HRD
testing
testing?
is advised for all ovarian cancer patients, sir. High-grade serous ovarian cancer and grade 3 endometrioid ovarian cancer.
Means a new patient comes, you will send for BRCA and HRD together initially?
Sir, ideally we should do both together. If we do only the germline BRCA, then we will miss out on the patients who are somatic or HRD positive. If we do only somatic testing, we may miss out on the germline testing, sir. Germline positive patients.
So what is the percentages of each? Germline BRCA, what percent? Somatic, HRD, what is the approximate percentage?
Germline BRCA in ovaries around 20%, sir.
10 to 15.
Somatic.
Okay, then, yeah.
Somatic, I'm not sure, sir. 10
Around 7 to
15%.
10%. Yeah. So HRD will be the remaining. Isn't it? So ideally you will do, so what your practice is to do everything together, all together.
We do both germline and HRD. Yes.
HRD too, right. But then if you really look at the NCCN, where does this HRD help you? When does it help you? Suppose you're taking a new case. This is a little unusual case. A new case of CAORI comes to you. You are treating them with, ideally what will you give them? So the usual stage 3C, person with ascites, what is the usual management?
Usual management, we give them chemotherapy, upfront chemotherapy, and then neoadjuvant, followed by interval
Only chemo?
cytoreduction.
Only chemo? Something else.
Chemotherapy with bevacizumab, sir.
Okay. Then site reduction.
Then 3 cycles, followed by interval cytoreduction, followed by adjuvant chemotherapy. And depending on the response,
completion. Yeah.
Depending on the response, if they had a complete response or partial response, if the HRD is positive and the BRCA is negative, they're still a candidate for PARP inhibitors.
Okay. Is it really mandatory to get an HRD at that point of time? If they get a good response, what does NCCN say? Should you really look at HRD and BRCA at that point?
NCCN says to test for all patients from stage 2 onwards. Sir.
Okay. And what do you think is the percentage of complete that they'll tell of complete responses? No, in the clinical trial, what was it responses which they got? Complete responses. Optimal site reduction was achieved in what percentage? In the trials, it's less only around 40 to 45%. That's all. So the problem with us is that we really don't know what is the surgery, what is the, there is no way to assess the responses. No? So even in the landmark trials, the responses has been only to the tune of 40 to 45%. That is one thing to be wary of. That is why whatever options are there, we should try to give them. Like we can add something to the chemo, that will always be better. Fine. So in 2025, this patient is not having chemo sensitivity. So what are the other tests you would like to do other than BRCA, HRD, anything else? Money is not a problem.
If they're having, you have to check for MSI status, sir, and TMB. So if MSI is high, then there's an option of dostarlimab or pembrolizumab. And if TMB is more than 10, then there's an option of pembrolizumab, sir.
Okay. Anything else?
Then targeted therapies are there, sir.
Okay. Latest approval is for? Yeah.
Mirvetuximab soravtansine, sir.
What is the receptor?
Folate receptor alpha.
FR. So have you done that? Is it available, the testing?
We haven't tested for it, sir.
Yeah. No, I don't think many of us have done that because it's a lot of hype is there, but then the testing is in a separate platform. Okay.
So,
Any other charges that you want to test apart from this?
Yeah.
sorry, sir.
Is there any other charges that you want to test? You have to
So
hold,
do you want an
basically-
NGS? Will you do an NGS on it? That's a question.
In the recurrent settings, they have given options for BRAF testing, NTRK testing, RET testing.
All are there.
Yes.
And even HER2 is also there.
HER2, yes.
So if it's HER2 3 plus and HER2 also, you can give deruxtecan. So there is even newer data for that. So HER2 is something essential.
Yes.
So if the patient has now, let's say the patient has relapsed, you have started olaparib and she has relapsed partly within 6 months. It's quite unusual.
Yes, sir.
What do you do for this patient?
If she's
She'll
relapsed
come back
within
again
6
with,
months
a peritoneal. Within 6 months. Quite unusual, but she relapsed within 6 months.
if it's just 6 months, there's an option of again giving the patient a trial with carboplatin-based chemotherapy.
Yeah, you can decide upon a case by case. But within 6 months, so if it's on a 6 months, yes, bang 6 months, okay, you can take a call. But within 6 months, say if it's 3 months, 4 months, or something like that.
Yes, sir. Yes. Then we can give single agent chemotherapy, sir.
Okay, what would be a choice if it's a single agent
So
chemotherapy?
options are liposomal doxorubicin, sir. Otherwise, single agent gemcitabine.
Okay. Anything else?
Then there are cyclophosphamide is there, sir. Etoposide is there. Topotecan.
Irinotecan
Oral
also you can
metronomic,
give. Yes.
oral metronomic therapy.
Oral, yeah.
Because she's
Cyclophosphamide.
new poor tolerance to carbogemcitabine. So have you tried? Any data is there about oral metronomics? Ovary?
Cyclophosphamide low dose of 50 milligram once daily.
She may tolerance may be better now.
Anything else that you can combine? Yes. So OMCT regimens are there which includes cyclophosphamide, etoposide, and tamoxifen, but adding etoposide can cause monocytopenias. You have to be a bit cautious when you're adding etoposide along with the OMCT regimens. But yeah, if she has recurred so fast, then that's one option which we can think of.
Okay.
So, I think this is so BRCA part we have discussed. And how are you going to monitor her during follow-ups? Is it with CA-125 or should we really do CA-125 during follow-up of these patients?
So because she had a high CA-125 to begin with, we should follow up with CA-125. So.
Or you can just image her and based on symptoms only, or what is the lag time? You can run a rise of CA-125.
There can be a 3-month lag time, sir, between CA-125 rising and
more
the.
than that. So I think
what if the CA-125 is not elevated?
Yeah.
Sorry, sir.
So if CA-125 is not elevated, suppose CA-125 is not elevated in this patient, then how do you monitor for this patient?
And then we should do a history and physical examination, especially when the patient comes to us. We should do a PV and PR examination. Then symptoms, we should do
how
the
frequently
symptoms
do
of
an imaging?
Imaging ultrasound we can do, sir. 3 monthly for the first year.
Okay.
Then
any other markers that you can think of? Just like CA-125, is there any other markers? It's
so
not, we don't require.
So non-serous histology, sir.
So basically, you can look for HC4 is also there, but
Nice.
that's also another marker which you can look if CA-125 is not elevated. That's one marker which you can do, but not routinely, very commonly done. But that's something which you can answer in your. Yes. So suppose this patient is having a serious.
Yeah.
Yes, sir. Yes, continue.
Yeah. Proceed. Continue. Yeah. She's on olaparib maintenance, and after 2 months, she comes with again one more episode of pancytopenia. So what will you do? Yeah.
So ideally in these patients, we have to stop it and then we can restart it at a lower dose, sir.
Okay.
And try and see if she's tolerating that.
So you already put around 150 mg BD, no? That's the dose you would start with, isn't it?
Dose is actually 300 BD, sir. We started around 300 BD, sir.
No, but I think you started on 150 BD. You started on how much? Olaparib?
Olaparib dose is 300 BD, sir.
BD is a dose, but I think you told that but you told you started on a lower dose, isn't it? Already 150 mg BD. That's what you told.
Yeah.
Anyway, so you started on a lower dose, and still she comes with a pancytopenia after 2 months.
If she's not tolerating, we'll have to stop it, sir.
That's all. You will just stop and give supporting care, or you will do something more.
Not sure, sir.
No, is there any other bone marrow issues with PARP inhibitors can happen?
Sir, we have to investigate for MDS and AMLs.
What is the incidence in such scenarios?
In the first line, it is around 1 to 2%, sir.
Okay. Yeah, can happen. And particularly, what is more cautious is that carbogem cytopenia is very, very uncommon. So there is some amount of bone marrow problems happening there already. So you have to be very cautious about this second malignancies. That's why. So anyway, means so percentages are less, but it's a big high possibility in this case at least.
Okay.
So you have seen a lot of CA ovaries, no? Usually, what is the natural history? Usually
they have non-specific. They
so
have non-specific.
I will play the role of here speaking to examiners. I will be the patient's husband, who is an IT person working abroad, has come to meet you in the OP. So you have to counsel me, just like a MRCP exam. So I am asking you. So my wife is having a recurrence of the ovarian cancer at this point. So it's already come back. So so how are you going to counsel me as a patient relative about the way ahead? He wants to know how it is going to respond, whether she will relapse, and BRCA is also there. So can you, in 5 minutes, you can just counsel the patient's husband about all these things.
So I'm going to tell him that she had her.
I am him. You can talk to me. No problem. You can talk to me like the patient's husband. Yeah.
So your wife was treated for an ovarian cancer, ovarian malignancy 4 years back, and she's had a good response for the past 4 years. She was not symptomatic. She's symptomatic now. So this is something called sensitive platinum sensitivity, where we can where she has options, more options available in front of her.
That's all done. I have completed the surgery. My wife is on olaparib maintenance now. So I'm not sure how is it, whether it is going to come back again, doctor. And already she has got a mutation. So what should I do for that? So my main worry is that whether she will relapse again.
So there is a possibility that she can relapse, but when we compare patients who have received and not received olaparib, because she didn't receive it upfront, in those patients the PFS, that is the time to recurrence, is much larger than patients who did not receive olaparib upfront. And
so doctor, is it going to come back? Is the disease going to come back? Because this is what people ask. What answer you are going to give them?
There is a possibility it can come back, but for that we're going to keep her on regular checkup, and we're going to monitor her in the form of blood tests, imaging, and
rather than telling possibility, better to tell that ovarian cancer is, once it relapse, there is always, it is going to come back, isn't it? So nowadays people want such honest answers, isn't it?
Yes.
Dr. Rahul, what do you feel?
Agree, sir. And
so,
even you are going to get, the same husband who is going to ask you at ECMC, doctor, last time CA125 was 100, now it has become 240. What do you do? How long should you wait? How do you counsel the husband for this question? And she's asymptomatic.
So we'll the possibility that they did a trial where they for all the CA185 of patients who were asymptomatic and with raised CA185. They divided into two groups. One group received chemotherapy and treatment upfront, and the other group did not receive chemotherapy. They were kept on follow-up. So the patients who were given chemotherapy upfront, there was no added benefit either in overall survival or progression-free survival, and there were added toxicities. So if a patient if she's asymptomatic for now and she's anyway going to require treatment later, we can keep her on follow-up. And we can follow up again after 3 months, do an imaging, do a CA125, and then decide whether we want to start on treatment or not.
So what we can tell is that we are trying to preserve the drugs because the drugs are limited. So we are trying to avoid the toxicities and keep the drugs for a time when she becomes symptomatic. So usually that's how we tell, and most of them agree to that point. That is the only way. Okay. I think we are almost there. I think other than the if it is a PRP, if you missed, most probably they may not pass you. But anyway, so we have answered all the questions well, so that is fine. So just make sure that you don't miss on vital clinical examination. Otherwise, no further comments from my side. Anything, Rahul, you want to add?
No, sir, absolutely. Just the clinical examinations, just be a bit cautious on that. Don't miss a PVPR, exactly. Apart from that, nothing else. You have answered almost all of the questions.
And we understand that you have worked in the ward and you are aware of the natural history and problems of the disease. Good. All the best.
Thank you.
Back to Munir, Dr. Munir. Yeah.
Okay, thank you, Arun, and thank you, Rahul. It was a very good session. The presentation was good. I feel like everybody benefited out of this discussion which we had today. So thank you all. We'll come back the next month with a different case. So bye. Good night.
Night.
Thank you.
Thank you.